Hello, everybody, and welcome. My name's Lisa Swanson. I'm a dermatologist and pediatric dermatologist in Boise, Idaho, coming to you with the first session of Grand Rounds Atopic Dermatitis. I want to introduce you to my partner in crime. Go ahead, Douglas, introduce yourself.
Yes, it's an honor to be here with you, Dr. Swanson. I'm Douglas DiRuggiero. I'm a physician assistant. I practice in Northwest Georgia and Rome, Georgia. I've been a PA for the last 25 years doing dermatology. So I'm excited to be able to talk about some fun cases.
Yes, I think this is going to be awesome. During our 4 sessions, we're going to discuss several cases of patients we've seen with atopic dermatitis, and we're going to talk about the options available to them and how we go through that thought process of what treatments are right for what patients. And so without further ado, we'll go ahead and dive right on into our first case, which is actually a patient of mine. So this was a 12-year-old female with moderate atopic dermatitis. She had failed previous topical steroids as well as pimecrolimus. She's having a lot of trouble focusing at school because of the itch associated with her atopic dermatitis. So you can see in this picture the involvement around her mouth, and then in these subsequent pictures, you can see the involvement on her neck and in her antecubital fossa. And so I considered her to have moderate atopic dermatitis in relatively sensitive areas with involvement of the face and the neck. And I wanted to try to treat her topically, but had discussed at the visit that we could consider something systemic if it didn't work. And I'm of the mindset, Douglas, tell me how you do this. I typically will actually write down a list of options that I think could be appropriate for the patient and then see what the family thinks. Do you do something similar in your practice?
Well, yes. I mean, what you're basically saying is that we're trying to be as engaged as we can with shared decision making with our patients. And it really kind of brings a bigger question that we have as prescribers and clinicians on when do you decide that you're even going to write down systemics as an option? What is the decision making process? And do we have some experts like you and guidelines from our academy that would say this is when it's reasonable to make that recommendation to transition from just using topicals and trying topicals, and when do you think topicals are failing and when do we move on? So I mean if I have made the decision that systemics are really something that we need to consider, then I'm going to go ahead and write out the topicals we're going to try. Often insurance is guiding that on ones I need to try and they need to fail to move to the next step versus ones where I feel like we're not even thinking about systemics right now. So let's really give these the best effort we can.
Definitely, definitely. And so for this patient, I felt like she was really kind of straddling that line between management with topicals. Do you need a systemic? It's affecting school performance. And so when I wrote down kind of options for her, I wrote down a different topical steroid TCI regimen, come up with maybe a stronger topical corticosteroid, maybe the other TCI. I put option number 2 would be roflumilast cream, relatively recently approved, age 6 and up. For once daily use for mild to moderate atopic dermatitis. I wrote down topical ruxolitinib, approved for patients age 12 and up for twice daily use, our topical JAK inhibitor. And then I did actually draw a line, and then I wrote down dupilumab and an oral JAK inhibitor, just because I wanted her to know all the options, different strokes for different folks. And so I kind of opened up the discussion that way and said, what sounds good to you? And then she and her mom were able to kind of come up and help me with the plan for her. Do you want to guess what they chose, Doug?
Well, if it was my child, I would probably bridge them with topicals while the application for a systemic is cooking. Yeah. Just because of its, we can talk about how you classify moderate versus severe and how patient-reported outcomes impact that. But if she's not doing well in school and if she's not sleeping well, then systemics, I call it my green thumb method. I'm always planting seeds, to let them know, just like you did. You write it down and say, look, I really think that you're going to get the best relief potentially with these systemic medications, but we may need to try some topicals out first. And not that I don't think they'll work, but I think they really can give you some help. But maybe we should start an application process towards the systemic.
Yeah. Yeah. And so for this particular patient, we started topical ruxolitinib. And that was what the family chose, with plans to proceed to a systemic if we didn't see the kind of results that we wanted. But she's 12 and up, her BSA is less than 20%. And so she was a perfect candidate for the use of topical ruxolitinib. And she did very well. I can give you that feedback. She did very well.
Yeah, that's been such an incredible addition to our armamentarium, because it's just got such rapid itch relief in my hands. The itch relief is just almost within an hour of putting it on in some cases. Clinically, I see that. And so, yeah, it's been a very powerful tool, and being non-steroidal. And it's just, in my opinion, much since we finally have something that is very well tolerated and is efficacious. Now, I know that the new topical roflumilast has come out also, and as we gain experience with that, we'll have to see how that plays into our armamentarium. But we've had topical ruxolitinib now for enough time to really gain a lot of clinical experience with it.
And we know that topical ruxolitinib is a JAK inhibitor, and so it comes with that lovely boxed warning. How do you review that with your patients and their families? I can tell you how I say it, but I'd love to hear how you say it.
Well, sometimes I can do it if I know feel like I can kind of come across it in a way that can kind of catch them a bit off guard. I can say, look, this cream is not a steroid cream, but it doesn't mean that we don't have to talk about a few things that the FDA wants us to tell you about, And I say, I can look at the 12-year-old or the mom and say, how many packs of cigarettes do you smoke? And they're kind of like, what do you mean? And I said, how many heart attacks have you had? How many times have you been hospitalized for a clot in your leg? And they kind of laugh. They begin to kind of laugh. And I say, look, these are the kind of things that, based on a very older version of this medication that was in an oral form in patients who had arthritis and aren't even seen in dermatology clinics, some of those patients that were over the age of 50 had problems with these kinds of things. These are not the kind of things that we anticipate seeing in dermatology, particularly with a healthy 12-year-old like your daughter. But I want you to hear that from me first, so you don't go and pull it up online and read about it and wonder why I didn't mention it to you. So I think that these things are very reasonable. And besides, this medication is not the oral form of these medications. It's just topical. So I even think that the ability to absorb it is almost minuscule.
I think that's the most important thing, is to just make sure you're mentioning it to patients and their families so that they don't read about it later and get shocked and surprised. I have a spiel, as we all have our spiels for different medicines that we utilize. I say this topical ruxolitinib is in a family of medicines called the JAK inhibitors. And a few years ago, the FDA thought it prudent to put a boxed warning on all JAK inhibitors. That warning stems from a study on one of the pills used in a different disease state in a different patient population. And because of some safety concerns from that study, they thought it prudent to put the warning on the entire family of JAK inhibitors. And I say topical ruxolitinib is a little bit like Kendall Jenner. She's low drama, but she's in the same family as Kim and Courtney and Khloe and Kylie, higher drama. And I find everybody knows the Kardashians. It's 6 degrees of Kardashians. Everybody knows them. So that's how I explain it in clinic.
Like it. I'll use it. This is my case. This is a 6-year-old Hispanic female. She has Down syndrome, severe autism. She's nonverbal. The sweetest thing in the world, just such a cute kid, and her mother just so caring, and she's coming in, as you can see from this presentation on the right forearm, this large, almost plaque-like, it's not plaque in terms of its rays, but it's very confluent presentation of atopic dermatitis, which she's had pretty much since 1 or 2 months of age. If you can move to the next slide, you can kind of see, here's a presentation on the chest wall. She sits a lot in this mobile chair, so she's kind of bent forward, and where the folds are, I think it kind of keeps the skin a little more moist and macerated, so she doesn't have quite the outbreak you would see in the other areas. But it's on the legs, the groin. The legs, the groin, and the back are mostly clear. It's mostly on the extremities and this upper chest and abdomen. A little bit on the cheeks. She had younger. Don't see as much cheek involvement here as well. So move to that last one. So, this is a mom who's saying, I don't want any systemics. Okay. They've been on a number of medications for many other medical complications dealing with her autism and other things, eating right and appetite stimulation, just a number of different issues going on. Wants no more steroid creams. you know? And so, and I saw this child before we had the newest topical that's out down to age 6. So topical ruxolitinib was not an option. This is a 6-year-old, and topical ruxolitinib only goes down to age 12. And at the time of this case, I didn't have the option of going down and using, the topical PDE, the new one that's out now at age 6. So, the question is, what do you do with this? This is a good case for discussion. I can tell you ultimately what I did, is that, we talk about systemic steroids being used by a lot of folks. Not a fan of that, and we got good recommendations now saying we should not be doing those. You've got a weight of experts behind us, and then biologics, small molecules, all options, but she doesn't want systemics. The mom said, I just don't want them right now. Now, again, this is a situation where I begin to plant seeds. Yeah, I feel like I'm happy with someone says I really don't want them to be on anything systemic, but at the same time, I said, well, tell me a little bit more about your hesitations. So I want to make sure that they've been adequately addressed. She may have a false impression of the safety issues with the monoclonal antibodies, which are extraordinarily safe. I feel like the JAKs are as well, but I want to address those. Again, I may just be planting seeds, not there to twist the parent's arm and say, I'm going to convince you today to put your child on this. It may not be that visit. It may not be the next visit, but eventually if the topicals aren't working as well as you want them to, they're going to begin to say, what else is out there? Can we control this? Can they sleep better at night? So in this scenario, it's planting a lot of seeds, addressing maybe misconceptions or giving some reality checks to some of the stuff and giving your own experience to it. But here we're looking at someone that's doesn't want steroid creams, too young for ruxolitinib. I mean, I think you can kind of see our options are TCIs, crisaborole, and I guess now the new roflumilast. That's where we squarely land because of the guardrails put on by the parent. But it's more of an issue of talking about how do we address these types of presentations.
Yeah, I think if I saw this patient, tomorrow, I would be voting for a topical roflumilast. It's a once a day, non-steroid, approved age 6 and up, no limitation on BSA, and approved for mild to moderate atopic dermatitis. I think that would be a nice approach. But a couple things that are kind of special about this kiddo. First of all, she's on the autism spectrum, and a lot of those kids have tactile sensitivities, which can make the application of topical therapies really difficult for the patient and their family. A lot of things really burn and sting. And so this is the sort of situation where I would talk about dupilumab. And I'm like you, Douglas, I'm not going to force anybody to do anything, but a lot of people do have misconceptions, or they don't know, they might not know how good it could be. And sometimes I'll say, I see a lot of these patients with really bad atopic dermatitis, and they're on the spectrum, and topical therapies are just really challenging. And sometimes the idea of a once a month, estimating her weight, a once a month injection would be so much easier than trying to manage topical therapies every single day all the time. And sometimes if you just kind of mention it and plant that seed and kind of throw some information out there, that seed will grow and fester. And maybe at the next visit, if your initial plan didn't work, they're interested in dupilumab. I personally think this kiddo would benefit from Dupi.
Yeah, exactly. And my thoughts as well. And for that reason, here's what actually happened. With this, this is a patient that has state insurance, Medicaid within our state. So the new novel topicals aren't covered. In our state, crisaborole is not covered. The only two things that are non-steroidal covered are the 2 TCIs, pimecrolimus and tacrolimus. And so I went with pimecrolimus because of its lotion formula, and a little more stinging I have found with tacrolimus. And then I also did allow the mother to say, look, I think she would benefit from a very mild steroid to calm everything down. And so what I did is I wrote for triamcinolone lotion, and I had her compound the 1 container of triamcinolone lotion into the tub of CeraVe. They did a home compounding where they diluted the triamcinolone lotion even further. So I told the mom, this is a barrier repair cream. We're going to dilute it down to almost infantile strength, And so I want you to use this CeraVe compounded with this generic, mid to low potency topical steroid. Use that 2 to 3 times a day for the first week. do use the pimecrolimus at the same time. Let me see you back in a few weeks, and then planted the seed for the systemic therapy, which I would be pointing towards one of the monoclonal antibodies in this case. So yeah, it's an interesting case when you start off with guardrails. I mean, I think the teaching point with this is that sometimes be willing to challenge the caregiver to make sure they understand, and if their perceptions are accurate and they still don't want to have a therapy, then great, I support them in it. That's really kind of the teaching point with this. And the teaching point is to not run towards steroids systemically and try to convince them that we need to calm this down, so to speak, because of the potential for the rebound flare and everything else, which this child has experienced through other people in the past.
Well, thank you so much, Douglas. So that concludes our first session, you guys, but there's more fun to come. We're going to have 3 more sessions where we talk about atopic dermatitis cases. I hope you enjoyed this one, and please tune in to the next 3.